Hey, good morning and welcome to Open Mics with Dr. Stites. It's Wednesday, January the 11th. I'm Dr. Steve Stites, Chief Medical Officer at the University of Kansas Health System. How many times have we tossed out the phrase, hey, it isn't brain surgery, when talking about something that's easy? That's kind of like how I like to play football. There's a good reason for that phrase, as brain surgery is indeed one of the most complex procedures you can undergo, especially if cancer is involved. Today, we're going to talk to you about a new way to treat brain cancer, though, involving placing a 1-inch gauze-looking tile into a patient's brain. The best part, it works by giving off a full dose of radiation to the patient, so they don't have to keep coming back every day for weeks for traditional radiation therapy. There's a picture of it. It's just so different than anything you'd think about in the past. Joining us here in the Dolph Simons Jr. Family Broadcast Studios, Dr. Brian Milligan, a neurosurgeon here at the University of Kansas Health System, who turns out to do some of this kind of patchwork stuff. I don't know what else we should call that. You'll have to help me with the right name. And Tracy Mason, one of the first to undergo this new targeted radiation treatment using what's called GammaTile. And Dr. Dana Hawkinson, Hawkeye, it's the last time I'll ever use his full name, will join us shortly to give our latest COVID count. We're going to hope for some better numbers because we know nationally hospitalizations are up 15%. Thank you all for joining us this morning. Questions from our viewers are an important part of this program, and we want to hear from you. Get yours sent in to us now on YouTube, Facebook, Twitter, and the Medical News Network. You know, for years I've known I was going to do that, and today it just blurted right out there, FaceTube. That's pretty good. I just violated a bunch of copyrights. You can find those links right here on your screen. Jessica Lovell will join us a little later with those questions. All right, before we start, let me explain, or try to explain with the help of Dr. Milligan, a little bit about this device called a GammaTile. Once doctors remove a tumor from the brain, there is a leftover cavity. They immediately fill that cavity with several of these small squares of collagen. And collagen is like kind of a connective tissue. It's throughout the body. So this is not some funny substance. So collagen, about the size of a postage stamp. Each tile contains 4 tiny radioactive seeds called cesium. Is that right?
Cesium.
Pretty good. Cesium-131. Those tiles deliver targeted radiation to the area for about 30 days. Since the tiles are made of collagen, they are safely reabsorbed by the body and dissolve over time. Dr. Milligan, GammaTiles are not new. They are cool. Tracy is part of a clinical trial looking at their use for them. Talk to us about, okay, first of all, the tiles. Tell us how cool it is, and then how we're using them.
Yeah, thanks, Dr. Stites. The tiles are a really neat advance in radiation therapy for treating the cavity after we've removed a brain tumor. One of the advantages, it seems, is that when you implant the tiles at the time of surgery, the radiation is being delivered immediately while the patient is in and exiting the operating room. The seeds decay over a period of about 100 days and deliver about the equivalent dose of radiation that patients would get from some external source given after surgery. The radiation only penetrates about 5 millimeters, which is about 1/5 of an inch into the brain itself. The sponges themselves are about the size of a postage stamp, but they're very soft and pliable, and so if the cavity is round or a little irregular shaped, the tiles can still fit and conform to the cavity. And the advantage, it's thought, is that the patients can start getting their radiation essentially immediately instead of having to wait for later.
So is the goal to kind of coat the edge around, like if you take out, let's say you take out a tumor, and we know that there's a lot of tumor you can't really see, it's got little tentacles invading. Is the goal of these tiles to kind of coat the cavity to make sure we get all those little pieces, try to eradicate it as much as possible?
Yeah, so in brain metastasis, like what we're going to talk about later with Tracy, when you take out the tumor, often you can't take it out all as one piece, and there can be little microscopic deposits of tumor left over in the cavity. And so the idea is to coat the cavity like that to treat the most likely place that that tumor might be left behind, rather. That's the same area that's treated with radiation traditionally, but that radiation has to pass through the skin and the bone, and then it actually passes through the tumor cavity, back out the brain, and out the other side of the patient. So the type of radiation released by the GammaTiles only penetrates effectively about 5 millimeters. Now, we still tell patients not to let the family cat sleep next to the head and so on, because there is a small added amount of radiation that comes out through their head, but that's above background, what we usually get from solar radiation and so on. But it's not a meaningful tumor treatment type dose, nothing that could cause like brain swelling, far away or skin changes through and through.
So that sounds a lot better than sort of the blunt radiation you get with the beam radiation, this kind of local stuff. Is it as effective?
And that's the purpose of GTM 102, which is a clinical trial that we currently have going on right now for patients just like Tracy, who have a brain metastasis from cancer somewhere else in the body that's traveled to the brain that has been recommended for surgery. And we're comparing traditional radiation to the GammaTile radiation treatment.
That is just pretty cool. It does feel a little like science fiction, but I love science fiction, so that's a great thing. Okay, so Tracy, tell us about your surgery. We understand you had a pretty aggressive brain tumor.
I guess so. I guess it was aggressive because it traveled. I started out with breast cancer 3 years ago, and all of a sudden it just appeared in my brain. And I met Dr. Milligan on my birthday.
And what did you remember most about him when you met him?
The bow tie.
The bow tie. I was noticing the bow tie myself. And I don't have bow tie envy, though, but it is a standout feature. We'll have to recognize that.
Yeah. As soon as it was explained to me, the GammaTiles, I was like, really? Let's hit this from the inside out? I was like, let's do it. I didn't even think of it wasn't a possibility. Mm-hmm. I went home and everyone asked me what I was going to do, and I was like, oh, I'm going to do this. I'm going to do these GammaTiles. And no one even knew that I wasn't selected yet. So I found out the day that my surgery was explained to me that I was going to do these GammaTiles, and I was selected, and I had to wait 7 days. I had to go on steroids for 7 days. I hated those. I hated the steroids. Steroids never did my body good. But I did it. I was excited to do my surgery. My mom would say that I was giddy because I couldn't wait to get this thing out of my head. It was affecting my speech. It was affecting my walking. It was affecting everything. But I really noticed walking because the talking, that was the biggest change.
And just say, you seem like you're talking pretty well. You walked in here, you got on a high chair essentially, so
yeah.
How are you doing?
I'm doing great. I start chemo in the next week or so. I am metastatic now, which means I've reached stage 4 breast cancer. It was the exact same pathology as the breast cancer. So I think I'm doing pretty well, considering that it's been 4 weeks tomorrow that I did brain surgery. That's
impressive. And apparently you had a scar up there, so.
Yeah, I'm a little, there's a picture of it.
Not as subtle.
It's not subtle, but I can cover it with lots of my hair, so I'm happy about that. So.
We're delighted you're on the program, so thank you for being here, because it takes a lot of bravery to tell this type of story on this program. So thank you for that. That means so much to our viewers and our patients, I think.
Well, because I want patients to want to do this. This is, brain surgery sounds scary, but I wasn't scared. I was confident.
So what do you think of these tiles?
I think the tiles are potentially a great revolution, especially for somebody like Tracy. Tracy's a person where surgery was just obviously the right treatment for her brain metastasis. She only had one brain metastasis, and actually the scans of the rest of her cancer showed that everything was essentially invisible.
I think we have some scans too, so maybe we can show those.
Yeah.
You're kind of telling a little bit about that. the size of the tumor. I mean,
Yeah, so,
help us understand what's tumor and what's not here.
Yeah, so in the rest of our body, right, we really can't find cancer. We presume that there must be something microscopic active somewhere, but we can't really see it. And then on the right-hand image is a horizontal picture from her brain MRI from before surgery through the head.
It's like we're looking at, if you're kind of looking from the feet to the head, and you can see it, so that what's on our right is really her left eye. What's on, I mean, as we look it up.
Correct.
Yep.
So we're looking up from the foot. You can see the wrinkle of the right ear just on the left hand of the picture, and you can see the bridge of the nose up at the top.
Yep.
And the white circle at, what is that, about 7 o'clock toward the bottom of the picture is the tumor, and the dark change around it is the swelling. The left-hand image shows basically the same section of her anatomy, highlighting the swelling. So all of that extra hazy whitishness around the area where you'd think that bright spot ought to be is the swelling, is the edema. And
so she has a lot of swelling on that scan.
And that's very characteristic of brain metastasis. For the size of the tumor, the amount of swelling is typically much more.
Okay.
Tracy was in a really good situation, though, because with a single brain metastasis and no evidence of active disease in the rest of her, that's a condition called a solitary brain metastasis. And even though that's technically stage 4, the way Tracy described, these are people who can actually do phenomenally well for a long time.
Well, that's great news, and we sure hope you fall into that phenomenally well part. So, how are you feeling about things right now? Are you able to kind of go out and do what you want?
Yeah, I can do what I want. With the radiation, I have noticed taste changes.
Taste changes, okay.
Yes. And that's probably from the radiation. I've done radiation before, and it kind of did that before. So, things that are red are hot and spicy, and, typical radiation stuff.
Yeah.
I mean,
tired, a little fatigued.
Sometimes.
Yeah.
I don't let any of that stuff affect my day.
And do you have any other, what kind of restrictions do you have on daily life?
I don't think I have any.
That's awesome. And it would be a lot different for her if she had standard radiation to her brain, because I think most of those patients, they feel pretty crummy, right?
They sure can. I think that depending on how the cavity had contracted for Tracy, traditional radiation probably would have still been a 3 or 5 treatment regimen as opposed to 10 or something like that. But yes, the potential for skin breakdown would have been higher, and then definitely the chances for side effects from the radiation passing through the tumor cavity and through the adjacent brain would have been higher. Yeah. So it's fantastic to think that a month after surgery, she basically feels back to the way that she did before she developed any symptoms from this tumor. She's got a peripheral neuropathy that generally affects her, mobility and so on. But and this was sort of a second hit on top of that. But she feels like she's all the way back to normal from before any of those symptoms developed.
Yeah. So do you have any sense, I know it's a clinical trial, and we're going to talk a little bit because I understand you're in some others, but can you help us, do you think this is more effective than standard radiation, or is that, we just don't know and that's why we're doing the trial?
I think the answer has to be, we don't know and that's why we're doing the trial.
Okay, that's the appropriate answer, so tell us what you really think.
I think for brain metastasis, it may turn out to be at least as effective, if not more so.
I mean, even if there's fewer side effects, you've just made it a lot better for people.
Yeah, and the fact that the patients get their treatment immediately as opposed to having to put up with some kind of delay.
Yeah, and you said it's a 0.5 millimeters, so that's a pretty small level of. But could it be larger if you wanted it to? I mean, is there a possibility we have to figure out what the depth of radiation needs to be with different kinds of tumors?
That's an interesting question. The type of radiation emitted by cesium and the characteristics of the brain are such that the radiation is only going to pass a certain distance. Mm-hmm. Even if they increase the density of the cesium seeds in the sponges, the distance of penetration is going to be about the same. They've chosen an alpha emitter instead of a gamma ray emitter, and so on.
So are there other types of brain tumors this can work with?
So we do we are getting ready to open another GammaTile clinical trial called GTM 103, where we implant the GammaTiles in the cavity after the first resection of a primary brain tumor called glioblastoma. That is a more infiltrative brain tumor, and that trial compares GammaTile plus some additional supplemental radiation because the tumor penetrates beyond that 5 millimeter depth that the GammaTile will reach.
That was my question about the 5 millimeter thing.
Absolutely.
I was curious about that.
Yep.
Yeah.
To traditional radiation. It will still be very interesting because when we take out glioblastoma, by far the most concentrated area of infiltrated tumor is that first 5 millimeters, and the fact that those patients, again, can begin receiving their treatment immediately at the time of surgery instead of the typical 3-week delay that there is to get external radiation arranged and started, may prove to be the linchpin in the reason that GammaTile benefits those patients. So we're very excited. Hopefully that trial will be open here in the next 30 days.
Tracy, we understand this is not the first time you've been in a clinical trial, so A, thank you. B, tell us about some of the other trials you've been in.
The only other one I've done is chemobrain. And chemobrain, for a lot of people who have been on chemo, is forgetfulness. It can be like early dementia. Like people, they're like, oh, it happens with old age, and no, it happens with any age. I did relatively well on it. I've done lots of things at KU. I was a part of, I did speech therapy here that does chemobrain exercises, so I did really well because I implemented those strategies quickly. I just don't like to suffer from anything that can be fixed.
Yeah, I'm with you. And it's great. It's like those patients who go do their physical therapy, man. You just know they're going to do so much better. All these things do make a difference.
Right. No, everything. I've done everything there possibly is. I've done everything here.
Well, thank you for doing that, and we appreciate that you're here. We're sad you have to be here, though.
But real quick, you'll like that story of how I actually got diagnosed.
Okay.
I went to the ED. I actually my doctor had ordered an MRI, and I was like, I'm not going to the ER. I just got approved from oncology. I've done all these things. It can't happen. I went the next day, and I realized I had to schedule that. And the transfer guy here at KU, I'm a familiar face, was like, something's not right with you. And didn't even ask me, just took me straight to the ED.
All right.
And from there, it spiraled.
So you're part of the family is what you're saying.
Basically, I am so recognized here that down to the transfer people, they know who I am.
So cancer, but it can have a pretty big effect on your personal life, on your physical, all sorts of things. How have you tried to cope with all that?
I like to pretend it doesn't exist. I fix it, and if something goes wrong, I tell somebody, and I fix it.
So I like to say hope, faith, science.
Basically,
yeah.
Like I had complete confidence in where I chose to do my care, and I wasn't even scared.
Faith, hope, you're going to get better and do these things.
I
science,
do. Faith, hope, and science. I like to tell people if you're afraid of surgery, then you're not asking the right questions.
Yeah, that's great. All right, well, time to check in with Dr. Dana Hawkinson, Medical Director of Infection Prevention Control. Hawk, how are you doing?
We're doing good. COVID count, active infections are actually going down a little bit, which is good news.
It is good.
68 total. Of those, 37 are active. And Steve, we had about 10 in the ICU earlier in the week, down to 5, but still a large proportion on the ventilator. I think we had 6 at one point. 4 on the ventilator currently. So numbers are still higher than we would like. And overall cases that we know of, because again, we've always talked about this for quite some time now, there are less testing places. Also, people may not be testing or testing at home, so we don't always have the recording of that. But cases are pretty steady right now. And then, of course, you mentioned hospitalizations earlier in the show as well.
You know, I think there's an increasingly large number of Americans who are simply saying, gosh, I'm just done testing. If I have it, I don't have it, I'm just going to act, I'm just going to go, it's just part of life now.
Yeah.
And I think even people who aren't doing as many home tests,
Yeah.
which means that hospitalizations become the only real barometer we have, unless people are doing random testing, and that's all pretty much faded away. And hospitalizations across the United States are up 15%.
Yeah.
What's your crystal ball tell you about the next 4 to 6 weeks?
I think with this steady plateau of the number of cases, again, some of the delay in the case reporting, looking at the CDC, again, we've come out of some holiday weeks where some of the data isn't necessarily up to date. But I'm hoping that we can actually see a decline in that number of reported cases. And then, of course, we always know and talked about hospitalizations do follow those cases. Those case numbers by a week or two. So hopefully we will see, and hopefully our hospitalizations will be a bellwether of what we are going to see. Hopefully we can start to see a decline in the overall hospitalizations as well.
I hope. I'm a little nervous about that XBB 1.5 variant and just the holiday gatherings and people, even when they're sick, saying, yeah, I'm done. I'm not following all the precautions. So I'm a little nervous about how this is going to play out over the next few months. So we got the heat map that kind of takes a look at this for us, and I think it's looked, largely the same on the last few weeks. You are seeing a little bit more rise on the eastern seaboard, especially in the mid-Atlantic eastern seaboard, and in Texas, Oklahoma, and parts of Kansas, and then another one out west. These are the big outbreaks we have right now, and what I think it says to us is that there's still a lot of active COVID out there, and if we trace hospitalizations, we especially see some of these same things, and we'll follow it over time. My fear is about what happens to us in 4 to 6 weeks, because that'll be the outcome and the ripple effect. We've known that the ripple effect is real after holidays. We'll see how things go here at the end of January and beginning of February.
Yeah, and I think we should take some comfort in understanding that the large surge that we had with that original Delta, both in cases and hospitalizations, we never really saw that these past few months with Omicron, which is good, but we also understand that the most ill, or those people with the most comorbidities, those with the highest risk, are the ones that we are seeing in the hospital.
And I think that is true. Before, we saw people who are very young coming in the hospital for really bad disease. Not seeing that as much now. I think that there is some host immunity. I think vaccination has made a huge difference. And that has really protected the population a little bit. Let's talk a little bit, though, about this headline. We all remember back in December of 2021, the COVID drug Paxlovid was approved. It showed a nearly 90% reduction in severe COVID in high-risk people. But a study in the journal Nature says the drug has not been used to the extent expected. In fact, hundreds of people in the United States are still dying from COVID every day. It's still one of the 3rd or 4th leading causes of death in the United States. What do you make of that?
Yeah, I mean, I think there are so many aspects to this headline and this story itself. Number one, I do believe Paxlovid is and was a game changer. I'm still happy that we haven't seen clinical resistance out there. Obviously, there have been studies looking at that, but we can still use the drug. It's a single antiviral drug, which we can still use, which we don't see that a lot. Obviously for HIV, we're having to treat with a couple different antivirals. But this drug really works. However, there are caveats to it. People who are on different medications, there are absolute contraindications that if you're on 1 or 2 certain drugs, you cannot take it. So that is one thing. The other thing that we've seen, unfortunately, is that there continues to be disparities among populations with access to, number one, primary care. But we have seen this throughout COVID as well, and this continues to be a part. We've seen minority populations, especially with less access. Same thing for vaccines. We're seeing this here. Overall, I think maybe physicians aren't really understanding the use of this and how useful it is. We know that if you are vaccinated and up to date, and if you do get on Paxlovid, especially if you're those higher risk, you have a 95% or more chance of living, of reducing your risk of going to the hospital. So the vaccination and this drug significantly helps and lowers your risk of having those severe outcomes, especially if you're in the higher risk category. We know that some younger people go on Paxlovid. They've been up to date, they've been vaccinated, but they're having severe symptoms. Those people, what we've seen in some of the studies is that, you really aren't having that benefit of stopping the hospitalization, because those people probably were not going to go to the hospital anyways. But it's for those people that are either unvaccinated or vaccinated but have those significant risk factors that this drug is so vitally important to help reduce those risks of severe outcomes.
And we know it really works. There's no question
Absolutely.
to us about that. And people say, well, does it really work? Or it changes my flavor. Okay, a taste change doesn't happen to everybody. B, it really does work. C, it clearly cuts back on hospitalizations and death, and so it's pretty effective therapy.
And I think one more thing is we need to talk about this is the rebound. People are concerned about the rebound effect. The rebound effect happens with other viral infections. It also happens even if you don't get Paxlovid. But what we have seen is that if you do have a rebound in symptoms, you do not have those severe outcomes if you do get it. So I would say that fear of the rebound or concern for rebound effect is not a reason to not get Paxlovid, because it will reduce your chance of those severe outcomes.
Excellent. And Tracy, we were talking, you had COVID, you said early on.
I did. I had it very early on, and I was asymptomatic. I didn't have any symptoms except for my lungs.
Pretty darn good.
I thought it was good. Because I can't afford it.
Yeah, no, that would not. I think right now you definitely don't want to go get it, just as a thought. So.
No, I think I'll stay away from.
All right, Jess, I don't think there's any reporter questions out there, but community questions.
Yes, you know we have them. Good morning to you. Question from Mary. Are there any side effects from having GammaTiles placed in your brain? It looks like Tracy's done pretty well, but Dr. Milligan, any possible side effects?
The only real side effects of placing GammaTile are the same as having traditional radiation therapy, but they're limited only to the brain cavity. So the small risk of swelling or radiation-related injury to the surrounding brain. What we avoid with GammaTile compared to traditional radiation is the potential for slowing down wound healing, skin breakdown, skin-related changes, and the other potential symptoms for radiation passing through other structures on the way out, so to speak. So, for example, where Tracy's tumor was located, the beams of radiation, if they were given from the outside, would probably pass through some of the back of the throat and so on, and have more chance of affecting swallowing than anything that she's noticing now.
Jess.
So Patrick was paying attention. What happens to the cesium dispensers that are left after the GammaTiles dissolve?
The cesium. Yeah, we were talking about that. It sounds like they all get absorbed.
Yeah, so the collagen sponge that it's impregnated in, that's a normal body protein. It's just broken down and carried away by normal body mechanisms. The cesium decays. That's the radioactive product that decays. So it decays into nothing, essentially. The cesium is coated on a small titanium seed. The titanium stays forever, but we use titanium for lots of other implants, other places in the body. In fact, to make the window in Tracy's skull to do the surgery, when we put it back again at the end of the surgery, we use some small titanium strips and screws to hold the bone in place. So titanium is a very well described biocompatible material, and it's perfectly fine for it to stay there forever. It won't impair her chances to get MRI. It won't cause artifact or make the MRI difficult to interpret or anything. And then finally, the cesium coated titanium seed is impregnated on a small piece of suture material called Vicryl, which we use to close Tracy's skin, and it also dissolves over a period of weeks. So essentially the only thing that's left at the end is these small titanium seeds, and they won't ever cause any problem.
All right, so you can tell people you have seeds in your brain. You have a seed brain.
I don't even tell anybody.
That's not like a bird brain, right? Not a bird seed brain.
No,
not a bird
different. Not a
seed
bird brain. No, it's a seed brain.
I'm like, can you imagine? It's been 4 weeks tomorrow.
I have to tell you that to think that you had a major brain surgery, and that was that tumor looked a little deep. It wasn't very superficial as I saw it on the MRI. how's that saying? You're marvelous. I mean, it's really remarkable you're doing so well. And
It's having a good team behind
Yeah.
you that just makes the whole difference.
simply marvelous. All right, Jess.
I know. Tracy, you've been on our show many times. I think you look better than ever, so congrats. I'm so glad you're doing well. And Janet, by the way, said best wishes for Tracy. Thank you so much for sharing your story with us. So it just goes back to, we cannot talk about these things without patients like Tracy sharing those stories. Last question is kind of a combo. Who else might be, Dr. Milligan, a candidate for GammaTiles, and could this potentially replace traditional radiation therapy for tumors?
I think whether it replaces traditional radiation depends a lot on just geometry of an individual patient's tumor. These were actually first designed to give supplemental radiation to patients with a type of benign brain tumor called meningioma that grows from the inner lining of the skull and pushes down onto the brain after they'd been previously removed and regrown following radiation. So they've been used for meningioma. Obviously, we're using them for brain metastasis, and you heard that there's a opening clinical trial using them in gliomas, which is an intrinsic brain tumor. And whether it'll become indicated for other tumors in the future, I think depends on the type of ingenuity and imagination and invention and other things that drive clinical research. So the answer is we'll find out over the years to come.
Jess, this is just
And who else
cool.
might be a candidate?
So right now, I think just probably patients with those main three pathologies, with those main three kind of tumors. And in the future, I don't know, we'll just have to see. There are other radiation delivery options that might be better for certain kinds of tumors, like our proton therapy center, rather than GammaTile, which is really just delivering radiation to this very, very thin margin adjacent to surgery. So people who have open surgery for big tumors that might otherwise benefit from radiation might be considered in the future. But I mean, gliomas, brain metastasis, and meningiomas, that is a large percentage of the tumors that my colleagues and I take out these days.
It is pretty cool, though, and I think I'm impressed. Any other questions, Jess?
No, it's all back to you.
All right. So this has been a great conversation today. I want to thank all of our guests and Hawkeye. I'm impressed with this whole thing about GammaTiles. Is this being studied in other types of tumors across the body?
I do not know the answer to that question.
Okay. It is pretty remarkable, though, and I'm especially impressed by the story and the power of science again, because I just remember the days when people got radiation to the brain, they just didn't fare well. And this is such a remarkable change. I mean, to have you sitting here like this, I don't know if our audience can even appreciate it. You are our Damar Hamlin. I think about that story, and what happened was you watched Damar Hamlin go down the field. These incredible experts get to his side immediately, start all the and these people have practiced and trained. They're just like, you know, our teams here. They work, they practice, they train, and now the guy's walking around the hospital and doing great. 4 weeks out of brain surgery, you're doing great. You're up walking around, eating, yapping.
Yeah,
That's pretty good.
I caught it quickly. I caught it, in my opinion, I think I caught it quickly.
Yeah. Okay.
And I was at the right place at the right time.
Yeah.
I just happened to be here.
Faith, hope, and science.
Faith, hope, and science.
All right, final thoughts, Tracy.
I don't really have any fun. Well, I guess I do. Don't be afraid of brain surgery. I mean, I get it. It sounds scary. But I believe if you're asking the right questions and you're doing the right things, that it just falls into place. Like, it fell into place for me. I just happened to be in the right place.
And you were in the right place, and you've been a remarkable patient, so thank you. Dr. Milligan.
I know Tracy's recovery seems quite remarkable, and I think it is, but I think more and more these days this is the expectation as opposed to the exception to the rule. So to echo Tracy's point, to not be afraid if surgery is recommended for something significant, I think this type of recovery is something that we very often see. And the second thought I would have is just understand that there's all kinds of innovation happening all the time, and we're really lucky to have a lot of it happening here and to be able to bring a lot of it to our patients. So I think it just predicts better and better outcomes for our patients as time goes by.
Yeah, that's so true. We're
Yeah.
going to come back to that moment, Hawkeye.
Yeah, I'm going to piggyback on that, and you know, both of the points of our guests, and it's just so vitally important to have those comprehensive teams, those medical teams, not just one person, but those teams, so they can collaborate and really get you through and get your loved ones through to have that quality of life. And I think that's what you get here at the University of Kansas Health System.
You know, I've been in medicine for approximately a very long time, and I'm so impressed by what's happened in the pace of change. For so many years, we kind of bumped along in cancer therapy, another chemotherapy here, another chemotherapy there, and life expectancy went up by 2 weeks or 4 weeks, lots of toxicity, et cetera, radiation, lots of toxicity. It is such a different story today, and we've seen it, we've borne witness to it on this program multiple times, whether it was CAR T therapy, transplants, and now the cesium tiles. I mean, that's the GammaTile. That's remarkable. It does feel a little more and more like Star Trek every day. But it is the intersection of faith, hope, and science, where you have great faith, or whether it's your spiritual side, and also the faith in the people you're working in. Hope, because hope is a powerful therapy. And science, just like that vaccination coming true in under a year for COVID, that is remarkable. And here we are again witnessing another miracle of the modern age. It is a great time to be alive, because you can stay alive, including having had brain cancer. Awesome. Jess?
Dr. Stites, thank you so much, and thank all of you for watching us today. Tomorrow we'll have an encore presentation of our morning medical update, and then we'll be back on Friday at 8 with our next live morning medical update. So until then, have a great day, and we'll see you back here.
He took a bullet to help a stranger in a bar 5 years ago. I'm Jessica Lovell. In our Where Are They Now series, we take a look back at the heroic act that fractured a vertebrae in Ian Grillett's neck and barely missed his carotid artery. We hear from Ian about what he's doing now and how a level 1 trauma center saved his life.
Subscribe to our morning medical update and open mics with Dr. Stites podcasts. Now, everywhere podcasts are available.